Greetings again, followers. We're going to talk here about gastroesophageal reflux disease, or GERD. And this is one of the more common things that you're going to come across in the wards or in the clinic, particularly among middle-aged to elderly adults. However, you can certainly see it in children, even in little babies. We are particularly concerned about this because if this is not controlled properly, if this goes a long time without being treated, without being managed, it certainly is a risk factor for cancer. And by cancer, I particularly mean esophageal cancer, and that is the adenocarcinoma of the esophagus, or the esophagus that tends to happen in the distal esophagus. And GERD is a big risk factor for that cancer. So here's our schematic of the digestive tract, and if you haven't seen the esophagus disorders, you should probably go back and look at those. But either way, we're now here, so we're talking about a disease that primarily affects the lower esophageal junction and the tissue slightly more proximal in the esophagus. So GERD is the #1 diagnosed cause of epigastric pain. The #1 cause is going to be idiopathic, but the #1 cause that gets a diagnosis is GERD. And we'll talk about all of these in other sections. So what is GERD? Gastroesophageal reflux disease is the #1 identifiable cause of epigastric pain, and what it basically is it's the opposite of achalasia. So in achalasia, remember, we couldn't get the lower esophageal sphincter open, and so we had food accumulating in the distal esophagus, resulting in a feeling of fullness. Well, here we can't get the lower esophageal sphincter to close properly. So what's going to happen is you're going to have backflow of the stomach contents splashing up against the lower esophagus. And that would be okay, but the contents of the stomach are very acidic, and the esophagus is not designed to handle acidic contents. So when you get the contents of your stomach splashing up against your lower, middle, upper esophagus, you're going to have pain, and that pain is described as burning. So these patients describe a substernal pain. And now normally we would worry about that because we would think of the heart, because angina is substernal. But when you ask these patients the nature of their pain, they'll point epigastric pain, and they'll say it radiates up into the substernal area. Furthermore, they describe their pain not as crushing like we would see in angina, but as burning or as heartburn. Other symptoms that you can see in a patient could include sore throat, hoarseness, cough, wheezing, bad taste in mouth. A lot of them will describe this as metal-like they put a bunch of nickels in their mouth. And some of them will have came in with a past history of vomiting. You can also see alarm symptoms, which we'll discuss, and those are going to change how we treat the patient. So the sore throat and the hoarseness and the cough and the wheezing, all that is from the acidic contents of the stomach coming up through the esophagus and into the pharynx. It can go from the pharynx down the larynx and into the lungs, and so that can cause cough and wheezing. So really, GERD can get into the respiratory tract. So anybody with significant GERD, if they're in the hospital and they have had GERD, and we definitely want to keep track of possibly pneumonia. So, but as far as basically GERD is concerned, just remember that it's substernal pain, yes, but it's also epigastric pain, and it burns. And the substernal pain is primarily radiating. And you get a hoarseness and a wheezing, and you want to make sure that the patient has not aspirated. So make sure that if the patient is being hospitalized, that you check for that. As far as the USMLE, what they want you to know for GERD, the #1 thing is to know the difference between the pain that you get from GERD and the pain that you get from other types of chest pain, namely angina. So a patient who comes in who's 38 years old and is experiencing epigastric pain that's burning in sensation and radiates to the sternal area, you're not going to get an EKG on that patient. They're young, they've got symptoms that are very specific for GERD. You're going to give this patient an antacid. So in a patient with presumptive GERD, your physical exam, you should pay special attention to the pulmonary system. Like I mentioned, wheezing, hoarseness, and cough can all suggest possible aspiration, and this should be documented. So if this patient does not need to be kept in the hospital, if it's not a hospitalized patient, then you should monitor it on your own. If this is a patient you're discharging, you should be sure and educate them and let them know if they start to have fever, or if their cough worsens, or if they feel short of breath, then they should come in and be checked out again. Another thing to look for on physical exam, and this would be more of a sign of chronic or long-standing GERD, is eroded tooth enamel, and that would just look like a silverness on the teeth. That has a specific look to it. I didn't put any slides in here of that, but it has a silver sort of look to the teeth. You can Google eroded tooth enamel and see what that looks like. It's very characteristic. Alright, so remember those alarm symptoms that I was talking about. In patients with reflux disease, we want to keep a lookout for alarm symptoms. Now, anyone who's over the age of 45 who we suspect gastroesophageal reflux disease, we're going to want to scope them. And the reason we're going to want to scope them is because in this patient, they've probably had a long-standing reflux disease. Also, patients over the age of 45 are, by nature, at higher risk for esophageal cancer, which reflux disease also puts you at higher risk for. And those risks are multiplicative. So anybody over the age of 45 should be getting an upper endoscopy. Other symptoms you should be looking out for are symptoms that would point towards esophageal cancer. So weight loss, anemia, heme-positive stools, dysphagia, odynophagia, dysphagia and odynophagia because you'd have an obstruction, heme-positive stools because you've had bleeding, anemia, the same reason because you've had bleeding, and weight loss, either that could be from an obstruction or it could be from cancer. So these things, if any patient, regardless of their age, has weight loss, anemia, heme-positive stools, dysphagia or odynophagia, or they're over the age of 45, they need upper endoscopy. Now, if you have a younger patient, let's say 30, who's got symptoms that are very characteristic of GERD, you can proceed directly to clinical treatment. You don't need to do an upper endoscopy. If you have a patient with questionable GERD, they don't necessarily have all the stereotypic clinical features of GERD, or you have a patient who you've diagnosed with GERD and you've treated with PPIs and they continue to have symptoms, these patients should get 24-hour pH monitoring as well as manometry. Okay, so this is sort of another way to look at it. Any patient who is over the age of 45 should get upper endoscopy, and any patient who has alarm symptoms should get endoscopy. The patients who get pH tests and manometry are going to be the patients who have questionable GERD or persistent symptoms despite treatment, and the patients who are under 45 and have clear symptoms of GERD, you're going to start treatment. So here's what GERD can look like if you do an endoscopy. This is sort of a chronic inflammation, and this is the lower esophagus. Okay, so the standard treatment of care for patients with gastroesophageal reflux disease, if you get that young patient and they're asking you what's the first step in therapy of this patient, the answer is going to be proton pump inhibitors. And those are drugs like omeprazole or pantoprazole. They're all equally effective, so you don't need to worry about which one. You'll probably only be given one choice on the USMLE. So proton pump inhibitors is the standard, the initial standard of treatment for patients with GERD. H2 antagonists can also be used, but they're less effective. So if you're given the choice between proton pump inhibitors and H2 agonists, definitely go with the proton pump inhibitor. Lifestyle modifications are advisable for any patient with GERD, regardless of their age or risk factors. So things like weight loss, avoidance of nicotine, alcohol, caffeine, chocolate, fried and fatty foods, those should all be avoided, of course. Smaller meals should be planned at night. The bed should be elevated about 8 inches. And sleeping left lateral decubitus is advisable. And why is that? Because your lower esophageal sphincter opens up to your esophagus from left to right. So if you sleep on your left side, gravity is going to pull down the contents of your stomach away from the sphincter, and so that will help with your GERD at night. As far as avoiding food and water, typically the advice that is given is you should avoid food within 3 hours before bed, but really you should avoid putting anything in your mouth besides whatever pills you have to take at night. Because remember that the number one thing that causes release of acid is stretch. And so water and food will cause stretch in your stomach. Water will cause it even more. If you down 1 liter of water, that's going to be like having a full meal. So you definitely want to avoid food and water within 3 hours of bed. Now, if the patient doesn't respond to proton pump inhibitors, if they continue to have symptoms, say 8-10 weeks out, and you go down with endoscopy, you find Barrett's esophagus, we'll talk about that in a little bit. Any patient who's had persistent GERD symptoms despite maximal treatment, they are surgical candidates. And so what you will wind up doing is you're going to do a 24-hour manometry on these patients, or 24-hour pH measuring on these patients, just to ensure for the surgeon that this patient has GERD, and then these patients are going to go on to have a Nissen fundoplication, which is basically where we wrap the top part of the stomach around the esophagus, around the lower esophageal sphincter, to give it a little more strength. That's a surgical, you don't need to worry about the surgical technique. Just know that the ultimate treatment, if you fail maximal treatment with GERD, is a Nissen fundoplication. The number one complication that comes out of gastroesophageal reflux disease is Barrett's esophagus. So what Barrett's esophagus is, it's a histological diagnosis. So Barrett's esophagus on upper endoscopy, when you put the EGD down into the patient and you look, it's going to look like inflammation, but it's very important to note, at least for clinical uses, that not all inflammation is Barrett's esophagus. So this is inflammation from GERD. It might be Barrett's esophagus or it might not be. But inflammation does not always mean Barrett's esophagus. Barrett's esophagus will generally have inflammation with it, but inflammation does not always mean Barrett's esophagus. So that's important to know. So Barrett's esophagus is a histological diagnosis. You're going to need to get biopsy anytime you see an inflammation. Anytime you see inflammation in the esophagus, you want to get biopsy. When you have the biopsy and you have squamous to columnar changes, so what that means, remember that the esophagus is the esophagus is always squamous epithelium. The stomach is columnar epithelium. What do you think the body's going to do to protect itself from acid? The esophagus is going to do to protect itself from acid if it's constantly being exposed to acid splashes all the time. It's going to change into columnar epithelium. And the reason it wants to change is because the columnar epithelium can then protect itself from the acid. And so squamous to columnar changes is what Barrett's esophagus is all about. So that's why we need the biopsy to diagnose Barrett's esophagus. And so, like I said, it's due to chronic acid exposure. And the problem that comes with Barrett's esophagus is it's not just because you have squamous to columnar changes. That's not a big deal. But it's because when you have squamous to columnar changes, what you get is a metaplasia. And that increases your risk of developing adenocarcinoma of the esophagus, which, as you remember, is if you watch the esophageal slides, that's one of the most deadly cancers you can get. So you want to keep an eye out for this in any patient who's having GERD. You want to make sure that their GERD symptoms are under control. If their GERD symptoms are difficult to control, you want to make sure that you're going to get an EGD eventually. So this might be more of a step 1 question, but you may see it on step 2 or 3 because it's so important. As a matter of fact, I would probably say you would say it on step 2 or 3, so you're going to have to remember back to some of your step 1 material. So the histology is going to dictate how you treat the patient. And if you've ever worked with a gastroenterologist, they do have to pay attention to the histology. They might not have to look at the cells, but they have to know what the histology means and as far as treating the patient. So when you get the biopsy back on a patient who you think has Barrett's esophagus, if you just have your squamous to columnar changes, yes, the patient has Barrett's esophagus, but you only have to repeat the upper endoscopy in 2 to 3 years. So it's not that big a deal at this point. So repeat the upper endoscopy at 2 to 3 years if they have only histological changes. Now, if they have low-grade dysplasia, if the cells start to look a little funky, then you're going to repeat upper endoscopy at 6 months. So low-grade dysplasia, 6 months. If the patient has high-grade dysplasia, their risk for developing adenocarcinoma is quite high. So at that point, you're going to refer them to surgery, and they're going to get a distal esophagectomy. Of course, all these patients with Barrett's esophagus, this is just an accessory diagnosis to GERD. Some patients with GERD have Barrett's esophagus. Some patients with GERD don't have Barrett's esophagus. Barrett's esophagus only comes with GERD. So this isn't something that needs to be treated in and of itself. The way you treat Barrett's esophagus is by monitoring and by treating their GERD. So all these patients should always be on a PPI. And so this, as you see, looks just like regular old inflammation. But these happen to be Barrett's esophagus. So it doesn't look any different than inflammation. You got to get a biopsy, send it off to the histologist, and then you'll get your diagnosis.